say anything important in the first 90 minutes. Can somebody get that back door for me? My name's Paul Zoni. For those of you that don't know me, I'm an associate professor in the Department of Physiology and Pharmacology. I have a PhD in neuroscience, but really my graduate work and everything since has been behavioral pharmacology and a little bit of neuroscience. So, I've been here almost 15 years, I guess. And my research interests are in non-human primate models of substance abuse. And one of the reasons that I got interested in substance abuse is that what really interested me was aberrant behavior in a way. And so in substance abuse, people will do things that are very maladaptive in order to continue to use drugs. Okay, so this kind of had me very interested in the brain and in what are the brain processes involved in all that. And something that kind of goes right along with that are really strange, maladaptive sort of behaviors and thought processes that occur in a lot of other different psychiatric diseases. So we'll talk about schizophrenia tomorrow, and today we'll talk about depression. So that's kind of why I'm talking to you about this stuff. And so this is pharmacology class. So things that we're going to focus on are really learning about the drugs. So the learning objectives, and I will test really directly from these learning objectives. Okay, so if it's something you see in the lecture and you wonder, do I have to know about this? If it's not reflected in learning objectives, I'm almost definitely not going to have it reflected in the exam questions. Okay? So we're going to talk about we're going to go through different classes of antidepressant drugs and anti-manic drugs. In other words, drugs for bipolar depression. I want you to be able to know at least one example of a drug from each of these classes and know their mechanisms of therapeutic action. So how do we think they work to enact their positive therapeutic effects? And then also know about the mechanisms of side effects and toxicity, and that may involve other drug interactions and things like that. I'll delineate very clearly what the side effects and different mechanisms of toxicity are. But some of them apply to more than one class of drug. And so I'm going to probably give you a question or two about understanding about what those are or how a certain situation could bring about some sort of negative or toxic effect. And then really a key, if there's one take-home message, there's a slide in here that says take-home message, is the idea about why it's puzzled people for so long, both scientists and clinicians, that the neurochemical and neuropharmacological effects of these drugs happen almost immediately, when it takes sometimes 4 to 6 to 8 weeks to see any clinical effect. And we'll talk about why that is. At least why we think that is. Okay, so it's not a lecture on depression, but just to set the stage, depression, what we call major depression, is a devastating disease in the United States, and indeed and worldwide. And you can see, I'll give you some facts and figures on the next couple slides. But what I want to emphasize is the way you think about it is if you haven't ever been afflicted with this disorder or haven't known anybody with this disorder, this is what it's like. So, sometimes we talk, oh, what's going on? Oh, I feel a little depressed, this or that. We use that term colloquially to mean just sort of in a bad mood or sort of disappointed about something. Maybe you got a bad grade on an exam, or you're just not feeling well, or you had some kind of a issue with a friend or a family member, and we use that term colloquially, but the way that I heard it described that really impacted me the most was somebody said, think about the saddest you've ever been, right? And maybe it's because of death of a family member, a parent, something like that, breakup of a relationship, something like that. Just the saddest, acutely saddest that you've ever been. And then imagine feeling like that every minute of the day, from the time you wake up to the time you go to bed, not knowing why that is, and feeling like it's never going to go away. Okay, that's what it's like for people that are afflicted with major depression. And so again, just some figures about it, it's very high prevalence. It's usually an episodic disorder, and what we mean by an episode is a discrete period of time with altered functioning. So usually what happens is it happens a few days at first, and then it goes away, the person's feeling better, it comes back, and the episodes are a little bit longer, and the symptoms are a little bit more extreme, and so forth. So it follows this chronic course where these episodes come and go and they increase. There's a high rate of recurrence, and of course the other thing that's associated greatly with depression is a high rate of suicide attempts. All these make it very serious disorder. So I think it's worthwhile also to set the stage to look at what are the DSM-5 symptoms of major depression. And they're up here above this first red line. And so when a clinician is going to diagnose somebody with depression, the individual needs to have 5 of these symptoms, at least one of the top 2, and it has to be daily for at least 2 weeks that the person has had these symptoms. So the key symptoms are a depressed mood most of the day, and then anhedonia, which is an inability to experience pleasure or experience things that normally are pleasurable as pleasurable. And then you see a lot of these other things: worthlessness, guilt, thoughts of suicide, and there's a lot of different physiological effects having to do with weight, having to do with sleep, having to do with sort of your level of activity. And interestingly, you can see it can be one or the other. It can be in either one of 2 extremes. So there's weight loss or weight gain. There's insomnia and hypersomnia. And different people have different mix of these symptoms. The other points about these is that in order to meet the diagnosis, it has to be a clinically significant impairment. So in other words, it has to actually start to impact the person's life. And also it can't be explainable by some other condition, like, for example, maybe they were, were on some kind of a medication or something like that, take a person off the medication and they're fine. It was just these are some sort of side effect of that. And then there's a number of other physical symptoms that go along with it. So this is a pharmacology class. We talk mostly about drugs. When is it time to intervene with some sort of drug treatment? And so it's when the intensity of the episodes begins again to interfere with the daily routine. So, a lot of the way this manifests itself is you don't want to get out of bed in the morning. You don't show up at work because you just can't get out of bed because you're feeling so awful. And when the duration of these gets to the level of weeks and months, or the individual starts to have suicidal thoughts, and then it's time to consider some kind of a pharmacological intervention. And the key issue about treating with these drugs is what's called a therapeutic lag. And again, therapeutic lag is the fact that the clinical effects aren't observed for 2 to 4 weeks. And it can take up to 8 weeks to reach peak effects of these drugs. And so you can imagine that's very difficult in dealing with a patient. If you have a patient that's got a pain-related disorder, and they come in and they get some analgesic and they feel better right away, it's much more difficult to treat something like this when you have somebody that's in a very serious condition. They come in and you say, okay, we're gonna get on it, we're gonna start to fix your problem, but it takes 2, 3, 4, 5 weeks for anything to happen. It's a huge obstacle. And so just, I had looked a few years ago about some kind of numbers about the success, because that's another major issue sort of in the popular press and just in the popular thinking about these drugs, that they're not really super effective. And so what generally you see as a whole with antidepressant drugs is about 70% of patients will show a 50% decrease in symptoms over 8 weeks. Okay, that means 30% get no relief whatsoever, or less than 50% of resolving of their symptoms. So that's pretty low. I mean, that's you have 30% of people that aren't going to get any kind of relief at all. And on the flip side, only about 30% of people will experience remission with one drug. So very commonly, multiple drugs and multiple different treatments need to be tried in order to get clinical success. So this is sort of an outline. It is an outline of the rest of the lecture. And then just to let you know, if you have the slides, most of you probably looked at the slides. At the end, I have a section about animal models. And basically, that's there. If we get to it, great. If we don't get to it, we don't get to it. And I'll be happy to talk about it if you have any questions about it. but I'm not going to rush to get to it. If we don't get to it, it's not going to be on the exam, so we'll see. So, but this is an outline of the drugs we're going to talk about. The major pharmacological and non-pharmacological antidepressant treatments. I'll just briefly talk about the non-pharmacological approaches. And then we'll talk about mood stabilizers, which are the anti-manic drugs, or the drugs for bipolar depression. And so this is sort of a summary of the progression and the development of antidepressant drugs over the last 60 or 70 years. Prior to the 1950s, and we'll talk about this tomorrow too, especially when we talk about antipsychotic drugs, people that were depressed or people that had schizophrenia were essentially locked up in mental institutions, sanitariums, and basically watched over so they wouldn't hurt themselves or hurt other people. And that was it. I mean, before that, pretty much the treatments were, you know, we were bleeding people or we were drilling holes in their skulls to let the demons out and things like that. But that's not that long ago that this was the way that we were treating these people. And since then, since the pharmacology has begun to come into it, there's been a couple of sort of phases that drug development has gone through. So we'll talk about these drugs, the initial antidepressants coming about in the 1950s. These drugs, for example, the monoamine oxidase inhibitors and tricyclic antidepressants were discovered serendipitously. It just turned out they worked, at least in some people. And in general, pharmacologically, these drugs are very broad-acting, and they were seen to be relatively unsafe. They had a lot of side effects that made them dangerous. But the benefit is that the mechanisms of these drugs were identified, or potential mechanisms that could be targeted for antidepressant efficacy were identified with these drugs. Then in about the mid-'80s, there was another phase sort of developed when the SSRIs came out. And here the idea was, okay, we could target these to specific mechanisms, and it turns out that they were much, much safer. They weren't necessarily all that much better in treating depression, but they were much, much safer, which means they could be prescribed to a lot more people. And then sort of in the last 15, 20 years, because the SSRIs haven't been much, much more effective, the thought has sort of been, well, maybe we need to broaden it back out a little bit, not get too selective, and bring in some of these other mechanisms, but be careful about it and not bring into the picture all these side effects. So that's a kind of a timeline. So I'll start by talking about monoamine oxidase inhibitors. Even though they're very, very rarely used, they're almost not used at all anymore, but historically they're important drugs. So Parnate or tranylcypromine is pretty much the most common, or Deprenyl sometimes you see, especially in clinical sort of work. So the way these drugs came about, so in the early 50s, they were developing anti-tuberculosis drugs, okay, drugs to treat tuberculosis. And they had this drug called isoniazid that was very effective. And so they were taking, you know, the medicinal chemists were taking the isoniazid molecule and they were making different kind of changes to it. And they came up with a kind of a cousin of it called iproniazid. And it turned out that, so they would give these to these TB patients, right? And back then in the 1950s, if you had tuberculosis, it was not a very enjoyable lifestyle. You were quarantined in these hospitals, you know, put in these big tents, and you're basically kept there in bed the whole time while you're being treated, if you could be treated. And so it was pretty miserable. It was much worse than what we think of as a hospital stay today, and it was prolonged. And so I wish I should have put the quote in here. There's a really funny quote. I think you can find it on Wikipedia about iproniazid, but the guy that said, basically the idea was, these people have absolutely no reason to be in a good mood, and it was bizarre, the mood improvement that they saw. Like, these people were actually, you know, giddy. And so they sort of said, okay, well, this isn't really going to be working for TB. It didn't do anything with their TB status, but they said, well, maybe we give it to these people that are, you know, depressed all the time. Which, by the way, that's kind of how things worked back then as far as taking drugs to the clinic, very different from today. And so it had these mood-elevating effects, and they started using it. And then in subsequent years, very quickly, they found the pharmacological difference was that iproniazid unlike isoniazid, blocked the enzyme called monoamine oxidase, and it became the first antidepressant medication. We'll talk about why it's rarely been used. Okay, so mechanism of action. So it blocks this monoamine oxidase. Well, what is monoamine oxidase? What does it do? So monoamine oxidase is a enzyme that's it sits either inside the cell on the mitochondrial membrane, or also there's some of it outside the cell. Essentially, its job is to metabolize monoamine neurotransmitters. Okay, so hopefully you guys are familiar with this by now. This is a synapse, and what happens is action potential comes down the synapse. Vesicles fuse with the membrane, dump their contents out into the synapse, where the neurotransmitters can interact with pre and postsynaptic receptors. Right? Hopefully none of this sounds new to you guys. And so for most of these neurotransmitters, dopamine, serotonin, norepinephrine, what happens is it's taken back up into the neuron, or I guess mostly, I haven't found a lot of evidence and research that says that this happens, but it's in this figure, and this is Cooper, Bloom, and Roth, which is pretty much the Bible for pharmacology, so I'm leaving it in. But most texts will tell you that it all gets taken back up, and inside the neuron it gets metabolized by monoamine oxidase, and that's how the signal gets terminated, right? The neurotransmitter gets taken back up into the neuron. And so you can imagine if you block that monoamine oxidase, you get less breakdown of the neurotransmitters, more of it can hang around out in the synapse, and you prolong those effects, right? And so that's how it works. So there's two forms of monoamine oxidase in the brain, A and B, and they have different preferences for different substrates, but those that are currently available are non-selective, so it's not really super important to the clinical pharmacology. These drugs are rapidly and completely absorbed orally, which is good, because it means you need to take it orally in a pill. Metabolized in the liver. The key thing about the sort of the pharmacokinetics of these drugs is that they're irreversible inhibitors, right? So when you have a drug that's an irreversible inhibitor of the enzyme, you stop treatment. The only way to get that enzyme function back is what? You got to make more enzyme, right? And that takes time. You have to make more, all that, whatever the DNA, RNA stuff, you guys learned about that. Make more enzyme, get it to the right spot in the neuron, and then you can restore function, right? So it takes about 2 weeks for that process to occur. So I already told you to know about side effects and things like that. This isn't a very important mechanism. Physicians have to be very careful about switching medications, because you can imagine if you have somebody on a treatment of MAOIs, you knock out all their monoamine oxidase, and they come in and the doctor says, well, it's not really working. Let's put you on a different drug, and it's going to do the same thing, boost these levels of monoamines, right? Now you have all these monoamines boosted, high dopamine and high norepinephrine. You don't have any enzyme to break it down. And you can have this synergy that occurs, and we'll talk about that in a little bit when we talk about the tricyclics a little bit more. But you can see how that could lead to a dangerous situation. So you have to be very careful about switching medications. The last thing to say about these drugs, because again they're not used very much anymore, this is why they're not used very much anymore. It's a situation called a hypertensive crisis that occurs. And there's a nice picture here you can look at, but essentially what happens is that the monoamine oxidase also metabolizes tyramine, okay? Tyramine, amino acid that you get in through your diet. And what can happen is that if you don't, when you have monoamine oxidase inhibited, tyramine can build up, spill out into the general circulation, and then can all over the body promote this massive dumping out of catecholamines, particularly norepinephrine. And so you can get this very rapid, massive hypertension, which can be lethal. And so really there's just a, you try to treat the symptoms to lower their blood pressure and so forth. But this is very, very dangerous. And in fact, it's not just tyramine. There's other sort of drugs, molecules that are in the same class as tyramine, like phenylethylamines, that are present in a lot of over-the-counter medications like vasoconstrictors, and they're President, a lot of foods. I think probably everybody here is probably eating at least one of these or does on a regular basis. So cheese, bananas, beer, or chocolate, or wine. I would guess that there's probably everybody has had one of those on at least one occasion, right? So leads to a very dangerous situation where patients' diets have to be monitored very, very carefully. And so essentially, this is why they're not really used very much anymore. But I introduce them because they're important historically, and they were the first ones to come along. Sort of more important in the early treatment of depression were the tricyclic antidepressants. The flagship of that is imipramine. So tricyclics, they're so named because of the three-ring structure that you see there. And a lot of these are still used. Amitriptyline, particularly. So how about the tricyclics? So similar to what we talked about with monoamine oxidase inhibitors. So they were, scientists back in the 50s were developing antihistamines. And I don't know too much about this, but we'll talk about chlorpromazine tomorrow, which was the first antipsychotic drug that came to be. So it turned out that chlorpromazine came out of this development of antihistamines. And so they were looking for more drugs that might wind up being good antipsychotic drugs. And so imipramine was one of the ones that came out of this sort of this medicinal chemistry effort. And so when they gave clomipramine and drugs like clomipramine, which is in the class called phenothiazines, imipramine didn't really work on these psychotic patients, but it worked on depressed patients. So that, combined with the unsafe situation with the MAOIs, led to tricyclics being the #1 class of drugs for treating depression for about 30 years. Even though, again, as I mentioned, limited efficacy. You have a large number of patients in which they're totally ineffective. Among the different tricyclics, they're pretty equally effective in treating depressive symptoms. They sort of differ in their side effect profile a little bit, and that's how a physician will decide which one to use. But still, it didn't have the acute dietary interactions with monoamine oxidase inhibitors. But as we'll talk about, they still have a lot of side effects, and they're rarely used today. At least rarely used as a monotherapy. Okay, so mechanism of action of tricyclics. These drugs block the uptake of monoamines, particularly norepinephrine, and also serotonin, but particularly norepinephrine. And so again, we talked about that process of neurotransmitters released, being taken back up through the transporter. That's what gets blocked by these tricyclic antidepressants. Okay. And I'll illustrate what happens kind of long term in a minute with that. But the key point is again that the synaptic levels of these neurotransmitters increase really within minutes, but it takes a long time, 2 to 3 weeks, for the clinical effects to start appearing, and even longer for them to peak through that therapeutic lag. And so why does that happen? We'll talk about that again in a minute. First, the pharmacokinetics. Again, they're absorbed from the GI tract readily. As far as the distribution, they distribute throughout the body, but a key point about this is that they're strongly bound to plasma proteins because they're very lipophilic. So you have that interaction that influences what goes on, and we'll talk about in a minute. That leads to side effects as well. They're metabolized in the liver, and they have a half-life of a couple days usually. Most of it is gone within a week. So there's a little bit of it is fairly long-lasting. Okay, so I'm going to illustrate sort of what happens with acute and chronic treatment, and that sort of gets into why we have this therapeutic lag. So here's your cartoon of your synapse in a normal individual. It's basically a norepinephrine synapse, but you also have dopamine and serotonin neurons that are in there in the mix, modulating what goes on here, okay? And so what you've got is, here's action potential, some activity in that synapse, some normal amount of norepinephrine that gets released. It binds to pre- and postsynaptic receptors, and you get some level of a cellular response. The process is terminated when it gets taken back up through the norepinephrine transporter, okay? Everything makes sense? And you got dopamine and serotonin floating around there as well. So the idea is that in a depressed individual, for whatever reason, you have lower levels of activity in this system, much less norepinephrine getting released, and less binding to postsynaptic receptors and a lower cellular response, okay, for whatever reason that is. And so again, here you got your norepinephrine transporter. So when we begin treatment, what happens is you put in your tricyclic antidepressant, it blocks that, so you don't get the uptake anymore. You still have low levels, but now your norepinephrine can build up outside the synapse, okay? And what you're going to wind up getting is overstimulation of these noradrenergic receptors, the alpha 1s and 2s, and the beta receptors. And what happens over time is that you get the typical effects that you would expect to see with alpha 2 and then beta receptors, which is they're overstimulated, and so the neurons downregulate those receptors. It turns out that you actually see an increase in alpha 1 receptors postsynaptically, and that leads to a normalization of the activity of the presynaptic neuron and the eventual cellular response of the postsynaptic neuron.
I might be thinking ahead, but like for patients who have depression, is it like on an individual basis where you have to see if it's because of monoamines or because of like serotonin levels, or is it just like a combination of medicines that they use for that?
So I'm trying to think if I'm going to talk directly about this or not. So all current medications right now target monoamines. So in a way the answer is, well, really the answer is no. There's no, that's not a stage in the diagnosis where they try to figure that out.
Okay.
Pretty much all treatments interact with monoamines. Now so monoamines being dopamine, serotonin, and norepinephrine, okay? Different drugs have a different balance across those, and they're more selective for one or the other. And so physicians might use that. So for example, if somebody has, we'll talk about in about 3 slides, a lot of the problems with these drugs are still cardiovascular, okay? So if somebody has some kind of chronic cardiovascular issue, a physician might steer away from the ones that have more of a noradrenergic component than a serotonergic component. But really my understanding of the field is that they pretty much have the ones that they like, that they've used, that seem to work, and they stick with that. But so there's very little of that, let me see what your phenotype is and get the medicine that's going to tailor to that. There's very little of that, unfortunately. And so there's not a lot of other options, but we'll talk about that, what else is out there and what's coming.
Bless you.
Hopefully. Okay, any questions about this process? So that seems to be what happens, and this is just basically saying in words what I just said. And this says, this slide kind of shows why those things might be beneficial, okay? So we see that alpha 2 receptors go down. Well, why might that be beneficial? Remember, we're starting with the idea that there's low monoamine activity. So the alpha 2s are presynaptic inhibitory autoreceptors. So you downregulate those, you remove some of that inhibition, and you can get more release. That makes sense, right? The postsynaptic beta receptors, one reason that might be beneficial is, as you saw in the diagram, those beta receptors are inhibitory heteroreceptors on serotonergic neurons. So they inhibit serotonin release. So you downregulate those, you remove some of that inhibition, you get more serotonin release. The alpha 1s are facilitatory heteroreceptors, we think. So they sit on serotonin and dopamine neurons, and they enhance release of these. So increasing those, it makes sense that that would be helpful. And then by blocking or downregulating the norepinephrine transporters, again, less uptake and higher extracellular levels. So it makes sense that all those changes would be beneficial. Okay, take-home message. So if those are the things that go on, why do we have this therapeutic lag? There's initial neurochemical effects, and eventually we have therapeutic effects. But why does it take some time? Well, it takes time for all these changes to happen. So you have initial neurochemical effects. You might need some changes in gene expression to make these receptors, right? There may even be epigenetic effects, right? I mean, this is, epigenetics is really brand new. You guys, I guarantee you guys know more about it than I do. I guarantee you've had more in your curriculum than I ever had in graduate school. But at any rate, these things have to happen. You get changes in protein production and changes in location. Growth factors might be involved, BDNF, for example. And this leads to neuronal plasticity and synaptic plasticity, maybe even neurogenesis. There's a lot of interest in neurogenesis as being important in depression, or deficits in neurogenesis as being causal in depression. And we know that neurogenesis takes about 4 to 7 weeks. And hey, what else takes 4 to 7 weeks? The onset of the therapeutic effects, right? And then eventually you get that. So it takes time for all these things to happen, so that makes sense. And I was at a conference a few years ago, and somebody used this analogy, which I love, so I put it in all my lectures on this. And that you have to make a distinction between onset and significant improvement. And so he used the analogy of a broken arm, right? So somebody breaks their arm, they go and they get a cast put on it, right? And it takes 6 weeks before you can get the cast off. And so until you get the cast off, you don't have use of that arm at all, right? No, you don't have any more use of it week 5 than you do the day that it gets put on. But that doesn't mean that there's not healing going on underneath that cast. And eventually, it's restored to full function. So same kind of idea. You might not see any improvement in function, but that doesn't mean that it's not going on. It just takes time. Okay. A couple other things to know, because this is a pharmacology class, about tricyclics. Tricyclics are broken down into active metabolites that have 3 important functions, or 3 important characteristics. 1, they're more selective for norepinephrine. 2, they have longer half-lives, so you're extending the half-lives. And then 3, the metabolites tend to have reduced side effects compared to the parent compounds. So what are the side effects, the key side effects? And this was very difficult to understand for students when I first started lecturing on this, because if you're thinking that these drugs increase norepinephrine, a lot of the side effects would come about because of decreased norepinephrine. And students had a hard time understanding that, and I had a hard time understanding that. But I want to point out that the reason that a lot of these side effects occur are because that drug itself can interact with, i.e. block, a lot of different other receptors, for example, in the periphery. So it's antagonizing receptors as well as increasing norepinephrine in the brain. So what are the sort of things that happen? The most common are you get decreased autonomic responsiveness, what we call anticholinergic effects. Okay, so anticholinergic, blocking acetylcholine effects. Specifically, it's muscarinic acetylcholine receptors. And these are the sort of things that we see. A wide sort of acetylcholine does things all over the body, so you expect a lot of a wide range of things: vision, cardiovascular effects, dry mouth is very common, and things like constipation and urinary sorts of problems. So those are the most common. The most severe are cardiovascular effects. In particular, orthostatic hypotension. Does anybody know what orthostatic or postural hypotension is, or how they measure it? Right. So that's they'll take your blood pressure when you're laying down and maybe stand up. And what's supposed to happen is, because there's an increased demand on your cardiovascular system, it's supposed to kick in, your blood pressure goes up. And so that's one way they measure for this poor reactivity. Somebody will stand up and their blood pressure will remain low. And that's how they know that these sort of compensatory mechanisms aren't really kicking in and aren't working. And that leads to dizziness and things like that. So. And that's because these drugs are blocking alpha-1 receptors in the periphery. So that has a lot to do with blood pressure, but there's also cardiac effects as well. And then there's a whole constellation of other things that may involve histamine receptors, and probably acetylcholine receptors and so forth. There's also toxic drug interactions that occur with the tricyclics. We talked about with the monoamine oxidase, the synergy. If you don't have any monoamine oxidase, same sort of thing here. If you're blocking the norepinephrine transporters or dopamine transporters and increasing dopamine and norepinephrine, the patient takes another drug that increases dopamine, serotonin, norepinephrine. You can get the synergy that can result in CNS toxicity, particularly things like seizures, and it could lead to death. Now again, we talked about that these are highly protein bound, so that means that there's going to be a lower effective serum concentration than what you might expect. And so if you give another drug that's also highly protein bound, it's going to compete, and more of that tricyclic will be in the blood than you expect. Does that make sense? So it competes. Also, you know, it makes sense that drugs that are metabolized by the same liver enzymes as tricyclics will compete for those enzymes. So you may have higher concentrations there than you would expect if the person wasn't taking another drug. And there's also drugs that will induce the microsomal enzymes in the liver. So they're taking this other drug, it'll actually cause production of more of the liver enzymes. And you can, which will metabolize the tricyclics faster also. You can sort of have a lower effective concentration than what you might expect. Okay, so those are some mechanisms of drug interactions. Okay, so moving on to the next class and the next era. Everything changed in the mid-'80s when Eli Lilly started to produce fluoxetine, or Prozac. It was a massive revolution in psychiatry, and particularly treating depression. More than 10 million people were taking Prozac in the late 80s and early 90s. A lot of people being prescribed these drugs. And so here's our list of some of the drugs. If you watch any TV at all, you'll recognize at least 3 or 4 of these guys. One of the distinctions here, too, is that the early drugs were selective for serotonin, hence the name SSRIs. And then, as I talked about it, things have sort of broadened out a little bit more lately, and so you have these serotonin norepinephrine reuptake inhibitors, or SNRIs. Really, they're sort of considered together, but the trend has been now more toward the SNRIs. The serotonin selective drugs still, though, are used very, very much. And the SSRIs are used also quite a bit for anxiety, and the SSRIs are more preferable there. Okay. And so these drugs now are typically accepted as the agents of first choice for treating major depression. And generally what you see in clinical trials, again, this is just sort of to highlight the moderate effectiveness. In a clinical trial, you would see about 65% responders in typical clinical trials. A responder means you get a 50% decrease in symptoms. But there's about usually a 30% response rate with placebo. So that's a pretty narrow window. So first of all, it's a pretty good placebo response, right? 30%. But it's 65% only with SSRIs typically. So that's not a huge effect. But about 35% experience complete remission. Again, that's really low. I mean, again, think of other disorders that you've heard about or talked about already. You know, if you have hypertension, you get on the right drug, boom. Diabetes can be completely controlled, 100% controlled, right? Depression, 35% people experience remission. The key point about why these are used so frequently is that it's a safer side effect profile than tricyclics and the MAOIs. They're not better at treating depression. And so again, we just talked about all these side effects with the tricyclics that occur because of their noradrenergic activity. Take out the noradrenergic activity, keep the clinical effectiveness, much safer drug. And this class contains the only drugs that are FDA approved to treat children and adolescents, which are fluoxetine and escitalopram. Mechanism of action is exactly the same as tricyclics, except for they're more selective. So the SSRIs selectively block serotonin. The SNRIs are more selective. They're selective for serotonin and norepinephrine. Usually, these drugs are very similar to tricyclics. They usually have a little bit less. And the key is that they don't interact with these other receptors out in the periphery. Same sort of issue with the therapeutic lag, however. And this is another opportunity. This is an opportunity for me to tell you that, keep in mind. Again, you talk about diabetes. We know exactly what's wrong with somebody that has, for example, type 1 diabetes, right? Exactly what's wrong. They're not producing insulin. We know exactly where the problem is. We know exactly how to fix it. But the fact that the SSRIs work, it doesn't mean that, oh, serotonin in some brain area that we can pinpoint, serotonin's job is to make you happy or elevate your mood. We can't say that. We don't know why a decrement in these monoamines causes these symptoms. We don't know where it happens. But it turns out that the drugs work. And I mean, that's really a baseline that runs through a lot of the psychiatry, is that the drugs work, and that's why they're used. We don't really know the deficit that the drugs are treating. And so I gave you a list of some of the changes that happen in the noradrenergic receptors. With serotonin receptors, there's a lot of preclinical evidence for a lot of different changes that occur. I like this quote that came out of an Irwin Luckey review. Basically, multiple subtypes are involved. It's not clear which ones are important. But here are some things that have been found. There's downregulation of 1A and 1B receptors and serotonin transporters. And interestingly, there's downregulation of there's evidence that the 5-HT2A receptors are downregulated by treatment, but also that they might be high in non-medicated depressed individuals. So I talk about this a little bit more tomorrow as well. It's tough to do these studies in humans, because you would need a bunch of people that have had depression for a long time or schizophrenia and have never gotten any medication to really see what is it about the disease. Otherwise, your human subjects have been on treatment for many years, different medications usually, multiple medications, and you don't know if you compare a non-depressed person to the depressed person, whether it's a part of the disease or it's an effect of chronic medication treatment. But with this 2A, there's a study with 2A receptor, a PET study, looking at 2A receptors that suggest that depressed individuals that have not gotten treatment actually have higher 2A receptors than normal non-depressed people. Okay, was there a question? Does anyone have a question, James?
Yeah, was the discovery of these SSRIs more of a targeted effort, or just certain?
Yeah, I don't know much about that, but I think it was designed to do that. It was designed to get rid of the noradrenergic component that had all these cardiovascular complications.
Gotcha.
And so that turned out to be a good idea. Whoever thought of that. Pharmacokinetics are very similar to the tricyclics. Orally absorbed, highly bound to plasma protein, metabolized in the liver, and have fairly long half-lives that are extended by the fact that they have active metabolites. Okay, they're a lot safer, but that doesn't mean that they don't have side effects. There's a lot of side effects associated with SSRIs. So there's a lot less cardiovascular risk. There's also no anticholinergic effects, and you don't see the sedation, which is probably histamine, interacting with histamine receptors from the tricyclics. But you do have, and so I've indicated what we think are the mechanisms here, but we don't really know extremely well. But the GI disturbances might be 5-HT3. Again, that's because we know that blocking 5-HT3 receptors can alleviate some of these. We don't know that there's no studies that pinpoint, for example, if you give a 5-HT3 agonist, will you cause these? We don't know. But we know that there's an antagonist that blocks some of them. So these are, GI related, a lot of sleep disturbances that occur, well-documented sexual dysfunction, and that occurs in women as well. It's widely popularized in men, but it occurs in women as well. And that seems to be, the sexual dysfunction seems to not be physical. It seems to be more like libido. Your libido goes down. You're just not interested. So that taps into this idea of anhedonia, which is interesting because anhedonia is a symptom of depression that you're trying to treat. There's some minor bleeding complications. The good news about this is that overdose is very, very rare. There's a very high therapeutic index, which I'll talk about more in a minute. But there is serotonin syndrome that occurs, and I'll talk about that again in a second, so I'll leave it for now. There are some cardiovascular effects, but usually at high doses when somebody's, so they're very safe. People, obviously will try to overdose on their medication, and it's relatively safe. The other thing about these drugs that needs to be brought up as far as side effects is, widely popularized, especially in the, starting in about the 90s, is a lot of controversy about suicide. So it's really, to me, also it's a really interesting issue. These drugs came out. A lot of people were saying, my kid was depressed, went to the doctor, got put on Prozac or Paxil, and committed suicide within 2 weeks. And there's this idea that they're so depressed that when they get on the drug, that gives them enough energy to get up and do something, which is commit suicide. And there were a lot of, for example, parent groups that were very vocal about this, got a lot of press, and it led to black box warning being put on all antidepressants by the FDA to be very careful about this. For physicians to be careful about this and monitor it very closely when they're prescribing these drugs. My take on it is, I think, it's a very serious complication, obviously. It's the most serious complication you can have. So being conservative and cautious, that's fine. That doesn't hurt anybody. However, I think it's kind of, the evidence really isn't there. There have been a lot of meta-studies and that sort of thing. And the medications really aren't implicated. And there's a number of reasons for this. First of all, from preclinical models, we know that increasing serotonin tends to decrease aggression and hostility. And then the other thing is you think about just sort of like a study design. And there's a lot of these, again, it's really hard to do this, but if you were going to actually design a study to try to examine whether SSRIs increase likelihood of suicide, what you'd have to do is take a bunch of depressed kids and give some SSRIs and then not treat the others and see which group has higher rates of suicide, right? I mean, but there's two things there that are completely unethical. Not treating a group and then waiting to see about suicides without intervening. So you could never actually do the study that we know as preclinical scientists would need to be done to demonstrate that, right? You could never do that. But the more compelling thing to me is that if you think about it, again, when does somebody go on medication? It's when people are kind of at their low point and they've got to go do something about this, right? So they're at their low point, which is the point where they're most likely to probably commit or attempt suicide anyway. And what happens? They go to the doctor, and the doctor says, okay, I'm going to give you some hope. We'll start you on this medication. The patient goes home, and what happens for 2 weeks? Nothing happens, right? And so this is like, finally I went and got medication, is not working. And so I think it's almost the lack of therapeutic efficacy that might enhance that, right? They're at their lowest, they try one last thing, and it's not working after a couple of weeks. So it's hard to blame the medication for it. There is evidence, however, that suicide rates have decreased since we started prescribing these drugs. And even, and if you think of, there have been people that have started on these drugs have committed suicide, but thousands and thousands and thousands of people have been helped by these drugs and probably did not attempt suicide because they were on the drugs. So, again, does that mean that I'm going to go out and I'm going to campaign for these black box warnings to be taken off? No, it's probably a good thing. We should be very careful with these patients. But a lot of people have tried to blame the drugs for increasing patients' desire to attempt suicide, and I don't think that that's really warranted. Okay. So some of the drug interactions that we see, a lot of them, again, very similar to the tricyclics because you have these concerns about interacting with plasma proteins and increasing their serum levels, the synergism with other monoamine increasing agents. Other things is that these drugs will very potently inhibit the liver enzymes that metabolize them and metabolize other drugs. So again, which is also similar to tricyclics. So if you have other drugs that are requiring these enzymes for metabolism, their levels are going to be increased. There's also some risk of bleeding in the stomach if patients are on NSAIDs. And along the lines of the synergy, there's a situation that occurs called serotonin syndrome, which is the synergy of two drugs that both increase serotonin. And it's interesting, and it's gotten a little bit more press people are trying to let physicians, especially physicians in the ED, know about this. Bless you. And what happens is, as you have this increasing interactions of serotonin increasing drugs, you go from symptoms that are very mild, like some sweating and tremors, then you start getting altered mental state, cardiovascular effects, and you can lead to severe hypertension, hyperthermia, and seizures that can actually wind up being lethal. So that's kind of a special case of this sort of monoamine synergy. There's also an interesting situation that occurs in discontinuation. Up to 20% of patients experience these kind of odd symptoms, and they can be mental, they can be sort of mood-based, and they can actually also be sensory, and all kinds of, you get so different kinds of blurred vision, you're hearing ringing in the ears. There's also this thing called lightning bolt syndrome where patients say that it feels like there's shock waves going through their body. And again, this is when they're off the drug. And so very, very little is known pharmacologically about this. But what is known is that someone that's on a higher dose of drug or that's been on a drug for a longer period of time has a greater risk of seeing these problems. It's also known that the shorter the half-life is, the greater the risk of problems. So for example, Prozac has a half-life of weeks, and you see mild symptoms in about 5% of patients. But with a drug like Effexor that has a very short half-life, you can actually start seeing these symptoms even if a patient misses a daily dose. So the solution here is to taper the dose down gradually, and again, the longer the half-life, the less time it takes to taper it down. So for Effexor, it might take weeks or even longer. And again, the reason you take somebody off the drug is it could be that it's not working, and you might want to put them on another drug, so the physician has to be very careful while you're tapering one down to taper in the second drug or start with a very low dose. Okay, the next group of drugs is sort of a catch-all category called that I just call atypical antidepressants because they don't fit into one of the other categories. And there's these 4 drugs here, and also used often as adjuncts are a lot of the atypical antipsychotics. And we'll talk about these more tomorrow, but you know, a drug like Abilify, you've heard a lot about, I'm sure. Seroquel and Zyprexa are used quite a bit, but used also in conjunction with these antidepressants. So just a couple of slides, a couple of pieces of information about these drugs. Bupropion is a dopamine norepinephrine uptake inhibitor, so it's a lot like a tricyclic, but it's not a tricyclic sort of a drug, structure of a drug. It has an amphetamine-like metabolite that can also block the norepinephrine transporter. So bupropion is Wellbutrin, and it's also Zyban. And as Zyban, it's used for cigarette smoking cessation. The unique feature of bupropion is it's the only one of these drugs that doesn't cause sexual dysfunction. Trazodone and mirtazapine are very messy drugs. Trazodone is an uptake inhibitor. It interacts with a couple of serotonin receptors. Mirtazapine also interacts with alpha-2 and histamine receptors, and it can increase serotonin norepinephrine release. And then buspirone is a 5-HT1A receptor agonist and also interacts with D2 dopamine receptors. This is primarily an anxiolytic drug, but it's also used for in depression. Some bullet points about the side effects and toxicity of these drugs. Bupropion has this hydroxybupropion metabolites that can act as a stimulant. So you see sort of stimulant type of side effects, agitation, anxiety, insomnia, and also can have appetite suppressant effects. Trazodone and mirtazapine, their main side effect is sedation. So typically these are given at bedtime, or if so you can see, for example, if the patient is depressed and overweight, you might want to use bupropion. You can treat both of those things. If they're depressed and they have some sort of like hyperactivity associated with it, or like insomnia, you might give trazodone or mirtazapine because it has sedative effects as well, so you can kind of get both of those. Trazodone is not used very much. It's also got some risk of that postural hypotension and other cardiovascular effects. including priapism. So priapism, and it's rare, but if you don't know what priapism is, it's an individual gets a sustained penile erection that lasts for a long time and requires an ED visit. Very painful. So it's the whole thing, when they say if your erection lasts more than 4 hours, contact a doctor, that's priapism. And that's not just a side effect of these ED type of drugs. It happens with these antidepressant drugs as well. Mirtazapine against sedation and weight gain. A lot are thought to be histamine related. So bupropion is weight loss, mirtazapine is weight gain and sedating. So it might be used, for example, in older adults that have some appetite loss. So you kind of match these to some of the symptoms that you see. Okay, before we finish with the antidepressant drugs, I wanted to make one point about a current topic of great interest, which are these rapid-acting antidepressants, right? So the idea is, how can we get drugs that don't take 2 weeks to kick in? And so there's been a lot of interest recently in drugs like ketamine. So, but really this goes back to the 60s, the original observations with drugs that are NMDA glutamate receptor antagonists, D-cycloserine and amantadine. But it's kicked in, and then ketamine, and it's really kicked in the last 5 or 6 years. There's been a lot more evidence. And so ketamine, most of us know it probably as a veterinary anesthetic, but at sub-anesthetic doses, it can have a lot of other effects. It can have reinforcing effects, abuse-related effects, but also antidepressant effects. The problem with these drugs right now, the roadblock right now, is that they're short-acting. So this graph here shows, I think these are 5 or 6 different studies. And this is the time since the last ketamine infusion. So you can see, basically what you're seeing here is the percent of patients that were classified as responders. So remember, other drugs, the level of responders are in here. With ketamine, you can get much higher level of response, but you can see that within just about 3 days, the effect is gone. So it comes on right away, but it goes away. So people are trying to figure out how they can sustain that a lot longer. But the most important thing probably right now is that it's focused a lot of the field away from monoaminergic mechanisms, which have dominated it for 70 years, and focused it now on whether glutamate might be involved. And that may lead down the road to medications that completely and totally lack any kind of these cardiovascular side effects or other side effects associated with serotonergic drugs.
So why not just give ketamine the first 4 doses of your antidepressant, so for a week or so you're immediately...
Yeah, maybe. I don't know if that might be so ketamine hasn't been approved for this yet, but that might be what happens down the road. Right now they're trying to alter this to plateau it out. But yeah, that's an idea, right? You get the initial effects of ketamine while the other mechanisms are kicking in. Okay, so I just want to point out in the next couple slides that there are a lot of other targets that people are working on. Some are based on HPA axis function, which is also known to be disrupted with depression. Some are based on indirectly altering these monoaminergic circuits, so glutamate receptors, also opioid receptors, number of different peptides. There's a whole bunch of other approaches looking at cytokines, looking at epigenetic mechanisms, looking at peptide mechanisms, and so forth. But this is just in the stage of early preclinical research. And then, of course, there's another number of non-pharmacological treatments. Psychotherapy is always going to be part of any kind of treatment plan. Also, these sort of electrophysiological sort of approaches, vagal nerve stimulation and deep brain stimulation like you see here, that are also being looked at clinically. Also transcranial magnetic stimulation is being used. I need to add that actually. And ECT, so these involved in these are all involved electrical stimulation of the brain. So I want to talk about ECT for a little bit before we go on to the bipolar drugs, because that's an important treatment as well. So why would you decide to treat somebody with ECT? Well, so you might have patients that don't respond to their drug treatment. cardiac patients who are at high risk of these cardiovascular side effects. So you don't want to give them a tricyclic or even an SSRI. And then any patient that presents with suicide, right? They present with suicidal ideation, or with often they present with a suicidal attempt. You don't want to wait 2 to 4 weeks for a drug to kick in. So a little bit of the history was developed back in the 1930s in use on dogs. And in the late 30s, 40s, and 50s, it began to be used in humans, and it was seen as very effective, and it grew quite a bit. And in 1975, this movie came out called One Flew Over the Cuckoo's Nest. How many of you guys have seen that movie with Jack Nicholson? That's pathetic. Go see this movie. It's excellent, excellent movie, and it also really has a lot to say about how we treat people with mental health disorders. But at any rate, it's interesting because 1975. Okay, the movie was made and released in 1975, but it's really based back in the 40s. It occurs in the 40s, and in this film, Jack Nicholson is in this institution, and it's thought that he's actually faking it because he wants to get out of a prison sentence. But they give him ECT, and it's seen as so he's taken in. He's on this gurney. He's being held down by these two big, strong orderlies, and he's looking around. He's very nervous, and they put a thing in his mouth so he doesn't swallow his tongue, and they put the electrodes on his head, and they zap him, and he's thrashing around. He's going, and it's a very frightening experience. It looks like a very frightening and painful experience. Now, that was actually a good representation of what ECT was actually like in the early days, in the 30s and 40s. One of the biggest complications was broken bones from the patient thrashing around during the treatment. But by the 70s, and since then, it's been the procedure's been modified and refined quite a bit, where you don't have that problem anymore. It's very calm. It's a very mild current that passes. You could if you saw it, you wouldn't even recognize that the person was having a seizure. You might see a little bit of contraction of muscles in the face or in the head, but there's no kicking and screaming and thrashing around and that sort of thing. But what was really interesting about it is that it had a major influence on people going to seek this treatment. And by 1980, it was being used in less than 3% of psychiatric inpatients. Over the years, then the efficacy of this kind of came out, and the NIMH put out a report in the early 2000s showing that you had 60 to 85% remission, and that's with a brief course of treatment. Remember, with the SSRIs, for example, you have 35%, and that's over months of treatment. So much, much better than any drug on the market, and so it's kind of grown again in popularity slowly after that. And so again, the procedure here, question?
On the past slide, you mentioned stuff about states regulating its use, and it seems like that is a reaction to the movie and pop culture.
Right.
What is kind of like the current regulatory feel for ECT and the lower current and safer doses, I guess?
Yeah, I think it's regulated, but it's used widely.
Okay.
And it's available widely, and it retains its good reputation as far as efficacy. So what happens is essentially it's an inpatient basis. Patient comes in, is anesthetized, electrodes are placed on the temples, a brief current is passed for about 30 to 60 seconds, and the seizure occurs. Patient wakes up, and this happens 2 to 3 times a week for about 3 or 4 weeks, and then that's it. So the side effects, there's a little bit of a headache sometimes temporary nausea, confusion, some stiffness because of the muscle contractions that occur. But that's very temporary, goes away within a day or so. The only issue that comes up with a longer term sort of problem is whether there's some anterograde memory loss for a brief time, like a period of a week or so. So anterograde means you can't form new memories, so people won't be able to remember things that happen within a few days after they've had a treatment. But that's it as far as long-term issues, much less serious than what you see with drug treatment. So some ideas of why this works. There's a couple of different theories. One is that, the kind of the obvious, which is that you have this massive seizure and it just turns on all these processes that aren't working right. It kind of resets the brain almost. and it could be changes in any neurotransmitter really in the brain. Mechanisms we don't really know. We don't really know about what, I wrote that twice. We don't really know about what receptors might be involved. But interestingly, I shouldn't say dopamine really, but really it's the first time I've mentioned GABA, which is inhibitory. And this is the only sort of technique that targets GABA. There's also what's called a kindling or anticonvulsant theory, and the idea there is that it's not that the patient has a seizure, but that what happens is the seizure occurs, and when the brain is having a seizure, all these other mechanisms kick in to terminate the seizure. So like these inhibitory mechanisms in the brain that are latent or that are dormant or not working right, that because of the seizure happens, all of a sudden they are called, marshaled into action and turn on and then remain on after the seizure, and you get normal functioning that way. And then there's a neuroendocrine idea that the seizure produces changes in hypothalamic or HPA axis function, and it's not just because it's a stressful event, but you get actual changes in the workings of the production of different hormones that run the HPA axis. Okay, any questions about any of that, ECT or anything? Okay, so the last little section here is medications for bipolar disorder. So we talked about major depression, which is often called unipolar depression, and related disorder is bipolar depression, right? Unipolar, bipolar. And so bipolar was described as a separate, distinct disorder in 1966. So we've known about this for a while, and so there have been different medications that have been developed to treat it. In a lot of ways, well, let me back up for a second. Not back up, but let me do this first. So the types of bipolar disorder, there's bipolar 1 and 2. And so bipolar 1, you have major depressive disorder, and you also have manic episodes. Okay? And so the manic episodes look very different, almost opposite from depressive episodes. So depressive episodes, the person feels worthless and guilty, very negative about himself or herself, has very low energy, low sociability. Bipolar, the manic episode is opposite. They have grandiosity, so they think very, very highly of themselves and what their capabilities are. They have tons of energy, they can stay awake, they can do things for days and so forth. So very opposite. And then bipolar 2 the manic episodes are a little bit less severe. The manic episodes sometimes have psychoses associated with them. We'll talk about that more tomorrow also. Bipolar 2 has lower incidence of psychoses and less social disruption than in bipolar 1. Then you also have cyclothymia, which are the sub-threshold kind of symptoms. They don't quite reach diagnosable level and they happen for a long time. And then you have this not otherwise, most disorders have this thing called not otherwise specified, where there's a lot of features of the disorder, but it doesn't reach the categories of these other ones. So mechanisms, what about genetics? Yes, there's probably genetics. There's been mild to moderate genetic effects, but that doesn't explain the whole disorder. There's this what's called biological rhythms hypothesis, and it's really not as much a hypothesis of a pathophysiological mechanism as it is a set of observations that there may be some relation with these sorts of things. So what's been observed is that there's seasonal peaks. So in the spring and in the fall, you get peaks in onset of symptoms, and also hospitalizations tend to peak for some reason. And so maybe that has to do with the seasons changing and that sort of thing. And also there's alteration in circadian rhythms in these bipolar patients, again, which we know are driven by our hormonal reactions to light, to daylight, and that sort of thing. And also alters sensitivity to melatonin. So there's some ideas that it has to do with that. Another idea is it's called the kindling hypothesis. So does anybody know what kindling is in electrophysiology and in epilepsy research? So one of the popular ways of studying epilepsy in rodent models is you can put an electrode down into the brain, and if you can stimulate with a low current and nothing happens. If you keep doing that at that low current, eventually you'll produce seizures, right? So it's like a sensitization to that low level of current. That's called kindling. That's you're kindling that animal. And so the same idea here with respect to environmental sorts of stress, that little by little a person becomes less able to deal with stress. Okay, so the drugs that are used to treat these are here. There's really two kinds of drugs. There's lithium and everything else, which are all anticonvulsant sort of drugs. And these drugs are called mood stabilizers because they don't just treat the mania. They treat both, they stabilize the mood. So they treat the mania without worsening depression. A lot of drugs, if you use an antidepressant, they usually don't work very well, or other drugs that can decrease the mania sometimes worsen depression. But these drugs are stabilizers, so, it says down here, right, so the antidepressant drugs, if you use it in a bipolar patient, the mania can get worse, okay. So the first drug, lithium, developed in the 40s in Australia, and again, you talk about serendipity, this guy was studying not even something that is CNS related, okay, he was studying the toxicity of uric acid in the kidneys. And so he was giving them lithium in the context of these experiments and realized that, this was in dogs as well, I think, and that they were much calmer. And so by the end of the decade, it was used as a sedative in humans, and he saw these really striking effects in these manic patients. And by 1970, it began to be used in Europe and throughout the world. In 1970, became the first line of treatment in the US. So the really cool thing, interesting thing about lithium is really the mechanism in the body and in the brain is completely unknown. Well, not completely, but it lacks a firm understanding of what the real therapeutic mechanism of action is. Lithium it's an ion, basically, right? It's a cation. It's not normally present in the body except in very, very trace levels. It has no effects in an individual that's not psychotic or not manic. So some ideas about what it does. It may alter, increasing lithium may alter the distribution of other cations, like magnesium, calcium, sodium, and potassium. And of course, these four you will recognize as being very, very important in things like maintaining membrane potentials, neuronal excitability, neurotransmission, right? So it makes sense that if you alter the distribution of those ions, you might alter neuronal functioning in some way. But lithium itself doesn't increase excitability, so it might be through that. And nitric oxide also might be altered. The other thing that it does is it can decrease the synthesis and block release of norepinephrine and dopamine. So, again, so this is exactly opposite of what tricyclics and SSRIs do, right? That they increase release of norepinephrine and dopamine and serotonin. So it kind of supports the idea that like the mania is opposite to the depression in some way. And it also has a number of hormonal actions that may be involved in some way in therapeutic effects. Another thing that is more recent is understanding of its ability to interfere with second messenger systems. So here it's shown here, here's a presynaptic and postsynaptic neuron, and in this case dopamine is increasing, binding the dopamine receptors and kicking in this phosphatidylinositol pathway, which eventually leads to increases in calcium intracellularly, which does a number of things that modulates excitability. And lithium can kind of get in there and block that cycle, so it can decrease intracellular calcium as well. And one way that can change brain function is to decrease glutamate neurotransmission. And again, glutamate is typically excitatory, so it sort of makes sense that you decrease excitatory neurotransmission in this highly active manic state, and you might calm the individual down. Although that's kind of a big leap from one to the other, but it makes some sense. Okay, pharmacokinetics, it's completely absorbed, again, because it's a cation. You very quickly get peak serum levels. There are extended release, sustained release type formulations that are available. There's no concern about binding to plasma proteins. Again, it's not a compound like these other drugs. It's simply an ion that gets in the body. The brain concentration is about half of what you see in plasma. There's no metabolic enzyme or anything like that. It gets excreted almost completely through the kidneys. Half-life is about 20 hours. The key the key, so the key thing about lithium and treatment and side effects are that there's a very low therapeutic index. Okay, you guys done therapeutic index? You know what that means? If I say therapeutic index, you've had it in IPP 701. Okay, so it's the ratio of the dose that produces therapeutic effects in 50% of patients, or sorry, lethal effects in 50% of patients to therapeutic effects, right? So the closer these curves are together, right, the more dangerous the drug is. Because if you want to get a drug that's effective in 100% of patients, it's going to be lethal in 70% of patients. That's probably not too good a drug. But you can get these far apart, and you can treat people very effectively without having any lethality. Well, lithium is very low. In lithium, it's about 3 is the therapeutic index. So signs of toxicity, there's some, you get tremors, motor effects, vomiting and diarrhea, things like that, and some arrhythmias. With those are the kind of early signs, and then the more serious, you can get mental effects, cognitive effects, seizures, and then that can progress to putting the person into a coma, and eventually irreversible damage, brain damage, and even death. This is a little bit repetitive here, but there's also endocrine effects that happen. There are renal effects that happen as well. You can imagine this is getting pushed through the liver. Polyuria, polydipsia, so the desire to drink a lot and then urinate a lot happens. So there's actually weird rashes that occur. So there's a lot of side effects with lithium, but it's very, very effective, which is what I say in this. But there's also, here's the drug interactions. First, there's interaction with NSAIDs where it can diminish the clearance of lithium. So if the person is taking particularly indomethacin, but also ibuprofen to some extent, you can have higher levels of lithium than would be expected otherwise. Sometimes lithium is used with antipsychotic drugs, and when that happens, you can get toxic encephalopathy. There's also a debate regarding possible kidney toxicity that happens with long-term use. That we know that if somebody is on diuretics or other sodium-depleting kind of drugs, that you can get an increased risk of kidney damage. I should move this slide up. But anyway, some of the issues about the therapeutic uses. So it's usually used to control and stabilize the mania. And it doesn't really affect the depression much, so sometimes you add an antidepressant. And sometimes it's actually given to people that just have a unipolar or major depression. So here's the high response rate. Up to 70% of patients respond, and it gets normalized within 1 to 3 weeks after that. So a very high response rate. It appears to be the best at preventing suicides. Even though, suicides, and I get asked this question, so I put this on here as a bullet. Suicides are generally highest in bipolar patients while they're having a depressive episode. This does still happen in manic episodes, and lithium appears to be the best at reducing that. Okay, and again, it's also sometimes used in patients with different psychotic disorders. So the other drugs are anticonvulsant drugs, and again, these are typically drugs that increase GABA or increase inhibition in the brain, and that fits with the idea that mania is due to some kind of overactivity rather than decreases in activity. So the first is valproate, and I try to just give you a little bit on these drugs, but it's often combined with lithium. It's not quite as effective as lithium acutely. So the mechanism of action of these drugs, they block voltage-gated sodium channels. So again, inhibitory in most neurons, and also facilitates GABA functioning. Rapidly absorbed orally. And these drugs, like the SSRIs, are highly protein-bound, metabolized in the liver, so you have that same host of side effects potentially that we talked about before. The side effects, most of the side effects and the common side effects are fairly minor. Some weight gain, some sedation, some GI upset. But the one exception is this sudden severe liver toxicity that can occur with valproate. Carbamazepine is another anticonvulsant. Mechanism and pharmacokinetics are generally similar to the valproic acid. It's mostly off-label, and there haven't been really long-term studies with it. And And again, here most side effects are minor. Overdoses can lead to arrhythmias and convulsions and perhaps respiratory failure, but that's very rare. And then the last one is lamotrigine, which is the most recent drug that's been approved. The interesting thing about lamotrigine, again, it has the same mechanism and so forth. One of the interesting things is that it treats depressive symptoms better than lithium and the other anticonvulsants, but it doesn't influence the mania at all. It doesn't make the mania worse. So it's often, again, used in conjunction with other drugs. The pharmacokinetics are highly variable. That's kind of the most dangerous thing. You have to monitor the therapeutic response. You don't want to be giving any more drug than necessary to have a therapeutic response. So they have to be monitored carefully. Other side effects are very minor, and interestingly, for reasons we don't quite understand, they're more likely to be seen in women. Finally, some other pharmacotherapies that are used for mania. We'll talk tomorrow about what typical and atypical antipsychotics are. These are essentially dopamine receptor antagonists. And then off-label, other drugs have been tried that are essentially drugs that facilitate GABA function. So anticonvulsant drugs have been tried, other drugs that boost GABA function. So gabapentin has been used. There's not really a ton of evidence for efficacy of those drugs. But because they're anticonvulsants and because of the sort of philosophy of how these drugs work and the problems that are underlying it, and other anticonvulsants have been tried. Benzodiazepines, of course, are drugs like Valium that are used for anxiety drugs. These are GABA A receptor agonists. Okay, so I've only a couple minutes, so I won't really go into this too much, but I'll tell you about a couple of these models of depression. So this is how drugs are being developed preclinically. And the most widely used and used for the longest time is what's called the forced swim test or the Forstall swim test. And so I'm going to make a couple of points about this, but the way that this is used is you have a cylinder of water that's deep enough so that a rat or a mouse's tail can't touch the bottom of the cylinder, and he can't hold himself up in the water, right? So he's going to be having to swim or float. And so what happens is you plop him down in this tank, and they try to get out for a little bit, and then eventually they stop. Okay, you take him out. Then the test really is done the next day. And so you plop the animal down in the water, and they basically do one of three things, theoretically. They either swim around in circles, they try to climb up out of the chamber, or they just float there immobile. And so basically when you do this the second day, so the first day they do all this kind of behaviors, the second day they become mobile almost immediately. And it turns out that drugs that are effective antidepressants, at least early on, drugs that were effective antidepressants would decrease this immobility, okay? Don't worry anything about depression, just that is, just on the surface of it, that's very useful, okay? Because you're gonna measure something and you give the drug, and if it goes down, this something goes down, it's a good clinical antidepressant. So it's going to be a useful model for that reason. Now, the problem is people have read a lot more into it. So the idea that a lot of people will take is that you plop them down the next day, they become immobile, and the reason they become immobile is that they have come to grips with the fact that their situation is hopeless, they can't escape, and they've given up. They've given up even trying to get out of their situation, just like a depressed person has, okay? You laugh, but this is a huge, huge problem in neuroscience and in pharmacology, that scientists think like this. So the next step is, well, if we can study this little dude's brain and see what's wrong with it, we can't take a brain of a depressed person and chop it up and look at receptors and this and that. But we can do that to this rat, and we can learn about the brains of depressed people, which is even farther from sound logic, okay? So I'm warning you against that, and I'm going to warn you to look for that when you're reading papers that involve animal models of depression or any other disorder. Okay, do they go too far in anthropomorphizing essentially what's going on in the subject? And the fact of the matter remains, clinically effective antidepressants will decrease this immobility. And therefore, it's a very useful predictive model for new drugs that come along. except that it might not be. It has really good predictive validity for monoaminergic sort of drugs. So here, for example, here's an example of fluoxetine and reboxetine, which is a norepinephrine selective drug. And the first column of both is immobility, and the columns are increasing doses. So you can see with no treatment, little guy is immobile 25, whatever this is, 25 minutes or something like that, 25 counts. And increasing doses, you decrease immobility. One of the interesting things is you can actually get some pharmacological information about these drugs as well. It turns out that all effective drugs will decrease immobility, but it has a little different profile, whereas with fluoxetine, instead of being immobile, they swim more. With reboxetine, instead of being immobile, they climb more. Whatever that means, you can get some, it turns out that that works with serotonin and norepinephrine drugs. But as we start to develop ketamine or drugs with other mechanisms, we don't know that it's going to work the same way necessarily. That this will be a good predictive model for drugs with other mechanisms. Maybe it's a good predictive model for drugs that increase serotonin and norepinephrine. It has nothing to do with depression, right? And the other thing that the argument that I like about it is, imagine if this was you in this situation, right? And you're in this situation on day one, and you make attempts to escape the situation, and you realize that you can't. And then in day two, you're put back in the same situation. What would you do? Would you struggle and struggle to try to get out of that situation again? Probably not. So the argument is that it's adaptive for the animal to maintain, to assume this immobility right away and not waste its energy trying to get out of the tank, right? Doesn't that make sense? So that's like really almost the opposite of what a depressed person is like, right? It's an adaptive, it's a smart thing to do, not to try to get out of the tank. So when you throw all that together, it makes it really difficult, and you will hear people talk about this as a model of depression. Okay? It's not a model of depression at all. It is a assay or a screen for efficacy of antidepressant drugs, potentially, and maybe not even all antidepressant drugs. Okay? So be careful about that stuff. That's a very sensitive point for you. You might be picking up on that. But at any rate, question. I want to stop there, but and take any questions you guys have and let you go.
On this model, do rats and mice in immobility, do they just sink? Do they float a little bit?
They float just like this.
Okay.
The other problem with this is I talked to somebody that works with this, and sometimes you get them that they dive down to the bottom and swim around and stuff like that, and they don't even know how to categorize that in terms of the swimming and the climbing. But yeah, they'll float. So their head's above water, but they're just not moving.
So they're not accepting their fate and committing suicide.
They're not committing suicide. No, no, commit suicide. Right. But they float. So they just float with their head above water. Yep.
I had a question about the vagus
Okay.
nerve stimulation, in the sense of like, do you know how that could be a non-pharmacological?
I know nothing about that.
Okay.
Sorry.
This is interesting.
but all I know is that it's an implanted sort of electrode that provides periodic, I guess, stimulation of that nerve, and that tends to decrease symptoms. And I don't think people care too much about the pharmacology of that because they know that works. But yeah.
I was about to ask the same question.
Oh,
Yeah.
it looked like you